During my tenure, the key priorities are really established by membership survey and then leadership survey over the last couple of years, and then personal interests that I have. But number one on all those lists are really advocacy for our specialty, because we're a small specialty. A lot of people aren't generally familiar with what we really do, and that's very important to us and to me. Also, it would be the branding of who and what we do. We're basically the enablers for a lot of other people in the hospital and in other aspects of medical care. So that's important. And then I think quality access for everyone, where they live and what they need in appropriate time, is really kind of the three major areas that I'm interested in. We have a list of 10 though that we're actually working on. And I think that we're not trying to minimize one over the other, but try to address the things that we can take care of and influence the best we can, and then just go on from there. Basically, 70% of all patients we take care of, in general, as vascular surgeons, are Medicare patients. So CMS, which is the one who determines how to interpret the rules or the laws that are made for us, they decide the rules and the regulations. And every little tweak that they make in how they pay us has a multiplying effect because there's a cap. So we essentially have a ceiling, and all of the House of Medicine have to try to figure out how to take care of the patients the best they can by an ever decreasing supply of funds, which really puts us in the perspective of worrying about whether we can actually keep our business going where our patients are and not go out of business. And you can well imagine the stress that puts on anybody who's supposed to providing or wants to provide good care, is worried that they won't be able to do that at the end of the year. And so it really stifles innovation, new avenues of care, and a lot of other things that we could be doing. So we really have to address the best way to have a stable business environment that provides great quality care and allows us to improve every year, rather than try to fight the same battles over and over again. The best way that I can explain what I think is important in clinical care, and that we are having difficulty sometimes providing, is we have areas both in the rural and in the urban community that are really vascular deserts. In other words, we aren't able to be where the patients are in sufficient numbers to really provide the care that they need. That's in rural areas. In urban areas, we may actually be right there, and yet because of problems with insurance or the choices they have to make between providing food and board for their family and then having medical care, really forces them to address medical care for themselves as a late spend, is really a problem that personally on a medical level we can't solve, right? That's really a social problem that we have to partner with other agencies to remedy. So I think we need to look at all the things that can affect how patients come to us, how early they come to us, and how effective we are in taking care of where they are in the care they need to provide the best care. So the Crawford session yesterday was really to provide a insight from 7 or 8 of our people who've done research in the area and have some opinions and data on what we're trying to find out, and then discussion on what we need to do. And there was a good discussion period that kind of made some points clearer and maybe other points that we didn't have to spend as much time on. So that's I think what's important to look at. We need to be able to go where patients are when they need us and provide the best care we can.